discuss something about Nocardiosis. We have classified systemic fungal infections. So in the first section of the first classification is affection caused by actinomyces. So this Nocardiosis also come under actinomyces infection. It's a chronic granulomatous inflammation caused by several species of actinomyces or related fungi. So it's a chronic granulomatous, the word is very important, chronic granulomatous inflammation caused by several species of actinomyces and or related fungi. And this Nocardia is capable of producing pneumonia like lesions or pneumonia, then disseminated disease, mycetoma, then lymphocutaneous syndrome or skin affections, and cellulitis. So these are the common manifestations caused by Nocardia. And these Nocardia species are common inhabitants of soil. It is mainly seen in soil. So the origin or the source is exogenous, or the agent comes from soil, or where in soil it contributes to decay of organic matter. So it is mainly seen in decaying vegetation or decaying matter. And three species are important or documented as pathogens. There are many species. Out of that, three species are important in producing disease or classified as pathogens. And they are Nocardia asteroides, Nocardia brasiliensis, and Nocardia madure. This Nocardia madure causes a condition called Madura foot. That we will discuss later. And this Nocardiosis is common in adults, mainly seen in adults, and especially seen in males, more seen in males. And epidemics are rare. Then person-to-person contact is also is not established or very rare. Then regarding the pathological features of the organism, it is a gram-positive, non-motile, non-capsulated, partially acid-fast, filamentous, aerobic organism. Then gram-positive, non-motile, non-capsulated, partially acid-fast, filamentous, aerobic organism. Then regarding the distribution, it has worldwide distribution. The characteristic histological feature of pulmonary or systemic Nocardia infection is formation of abscess or abscess formation. And this abscess is infiltrated extensively with neutrophils. This abscess is infiltrated extensively with neutrophils, and the granulation tissue surrounds this lesion. And nocardial mesotoma is characterized by suppurative inflammation with sinus formation or sinus tract formation. There is suppurative inflammation with sinus tract formation. So that's about the etiology. It is distributed worldwide. Then the histological features consist of abscess formation. In this abscess, you can see large number of neutrophils, and there is granuloma formation. And another important feature is formation of sinus tracts. So that's about the pathology. Then regarding the clinical features, there are several presentations. First of all, pulmonary disease. What are the features you get in pulmonary disease or pulmonary presentation? Typically, it presents as an subacute pneumonia. And it develops over a few days, and or the onset may be insidious also, developing over weeks. And the risk is more in people with deficient immunity or deficient cell-mediated immunity. For example, in patients with lymphoma or patients undergone transplantation. So it's more common in people with deficient cell-mediated immunity, that is, patients with lymphoma or after transplantation. Then cough is there with productive purulent sputum, associated symptoms like fever, anorexia, weight loss, malaise, dyspnea, pleuritic chest pain, then hemoptysis. All these are there in the pulmonic urethra. Then when we suggest an X-ray, or when we take an X-ray, we can see infiltrates of nodules in X-ray, nodules of varying size and density. varying size can be seen in X-ray. These nodules. Then in some cases you can see cavitation also. Then another finding you get in X-ray is empyema. Empyema is present. It is seen in about 1/3 of cases. In 1/3 of cases you can see features of empyema. Empyema means pus in the pleural cavity. Then pulmonary nocardiosis can spread directly from lungs. It can spread directly to pericardial area. It can extend to mediastinum, or it can lead to superior vena cava obstruction, etc. So it can be diagnosed by sputum culture. You can see fungal elements in sputum culture. So that's about the pulmonary presentation. Then secondly, the extrapulmonary dissemination from lungs or from other sides. It can spread to other areas. It's mainly through blood. The spread is through blood, or there is hematogenous spread. And the most commonly affected areas are brain, kidneys, skin or supporting structures, bones, then muscles. All these areas can be affected by nocardia. There can be pericarditis, endocarditis, peritonitis, formation of subacute or chronic abscess in several areas, formation of abscess in brain, meningitis. All these are common with nocardial infection. All these come under extrapulmonary dissemination. So that's the second presentation. Then the third presentation, important for us, is transcutaneous inoculation. It is seen in Madura area, or it's common in Tamil Nadu. It's otherwise called mycetoma or Madura foot or Madura mycosis. It's usually asked in examination. Examination is a common question you get in examination. Madura foot, Madura mycosis, or mycetoma. Here the lesion starts in the subcutaneous tissues. Later on it involves deeper structures including bones, and there is formation of sinuses, and eventually destroys the affected part. So it affects mainly the subcutaneous, the infection starts from subcutaneous tissues, then involves the deeper structures involving bones and other organs, leading to formation of sinuses and finally destroying the affected part. And this condition was first identified or described in Madurai in 1842 by a person called Gill, Gill. It is described in 1842 in Madurai. That's why it is called Madura mycosis or Madura foot. Then this is endemic in India. Not only in India, it is also seen in Africa, then South America, etc. In India, the cases are more in Tamil Nadu, mainly in Tamil Nadu, then Andhra Pradesh, Maharashtra. In all these areas, you will get this Madura foot or Madura mycetoma. Then the organism enters through an abrasion in the skin after a long incubation period. There is formation of granuloma. The organisms are seen in the abscess, and this is surrounded by a zone of inflammatory cells. And the inflammation gradually spreads along the facial planes. And the interesting feature is that the nerves and tendons are resistant or spared by the infection. So the infection gradually spreads through the facial planes. So if the foot is involved, the infection spreads through the facial layers. So the infection or the agent enters through abrasion in the skin, and the incubation is quite long. Then regarding the clinical features of this Madura foot, usually it starts as a small painless subcutaneous tumor. It starts as a small painless subcutaneous tumor, and the lesion slowly progresses and develops and it will destroy the part involved. And there is formation of sinuses, and these sinuses discharge pus, and this pus contains large number of organisms. And the most common site involved is the dorsum of foot. That's why it's called Madura foot. So the most common site involved is the dorsum of the foot. Then other areas like hands, then buttocks, back of scalp, orbits, etc. can be affected. Then there can be systemic symptoms, but it's very mild. The symptoms are more over the cutaneous areas. There are can be mild systemic symptoms, but it is not so prominent. Then when we come to the TD of this mycetoma, we have to consider chronic osteomyelitis. So since there is destruction of the tissues, the important DDs coming are chronic osteomyelitis, then tuberculosis, then syphilis, elephantiasis, or even neoplasms. All these are DDs for Madura foot. Then regarding the diagnosis of Madura foot, examination of Madura foot, the diagnosis in general, not this Madura foot alone. We can examine and sputum for examination. Then on examination of pus, or the pathological examination of pus, you can see beaded or branching gram-positive filaments. And most of the Nocardia are acid-fast. So acid-fast test, you can do suggest acid-fast test. Then they usually take up silver stains. Then in pulmonary cases or cases having respiratory symptoms, you can suggest bronchoscopy, then needle aspiration. Before that, you can do chest X-ray and routine examination. After that, this bronchoscopy, needle aspiration, then finally for confirmation, you can do open lung biopsy also. Then along with that, CT can be advised, MRI can be advised if there is brain involvement, CT and MRI of brain. Then regarding treatment of Nocardia, the important allopathic drugs are sulfonamides, then minocycline, etc. Then if there is a brain abscess or affection of brain, it should be treated surgically. If the diagnosis is unclear and the area is accessible, and if the abscess is very large, then surgery is the option. Then aspiration, excision, drainage, all these are effective. Then mycetoma can be, or Madura foot can be prevented by maintaining proper hygiene, regular use of footwear and all these are advisable. So that's about Nocardiosis. So it comes under actinomyces group of diseases. There are different clinical presentations. So it involves respiratory tract. Then from respiratory tract there can be dissemination to other organs. Then as far as India is concerned, the most common nocardial infection is Madhura foot or Madhura mycetoma. So that's about nocardial infection or nocardiosis. Thank you.